following episode is brought to you by the American Urological Association. This episode is part of a special series highlighting the AUA Update Series Volume 45. In this episode, we will be covering some of the key lesson points with Dr. Matthew Ziegelmann, one of the authors of Lesson 24, Case-Based Medical and Surgical Management of Peyronie's Disease. Now in its 45th installment, the AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology. For more information or to subscribe to the AUA Update Series, please visit the AUA University.
Welcome to another episode of the AUA University podcast. I'm Dr. Mark Gonzalgo, professor of urology at the University of Miami and chair of the AUA Office of Education. Today we're highlighting Lesson 24 of the AUA Update Series, Case-Based Medical and Surgical Management of Peyronie's Disease. This is a condition that nearly every urologist will encounter, whether you're in a general practice, a men's health clinic, or fielding questions after radical prostatectomy. What makes this lesson stand out is its case-based structure. Rather than simply a review, it walks you through 3 patient case scenarios and aligns with the ABU module on impotence, infertility, and andrology. So it's a really high-yield educational resource. It's my pleasure to introduce today's guest and one of the authors of this lesson, Dr. Matthew Ziegelmann. Dr. Ziegelmann is a professor of urology at Mayo Clinic in Rochester, Minnesota, where he also serves as an associate program director for the urology residency. His clinical focus is male sexual dysfunction with a special interest in the medical and surgical treatment of Peyronie's disease and erectile dysfunction. He serves on the AUA Medical Student Committee and on the board of directors for the Sexual Medicine Society. Matt, welcome to the podcast.
Thank you. It's a real pleasure to be here.
Let's start with the big picture. For the busy urologist sitting down with Lesson 24, how is it organized and how would you suggest that they navigate it?
Yeah, I think we took a sort of a new approach, at least in previous work that I've done. And the goal here was to provide kind of a brief overview of the condition of Peyronie's disease, a little bit about pathophysiology, natural history. And then we chose to do a case-based format because it sort of mimics what we see in real life. And that's that patients don't present just as, a question stem and 4 multiple choice, answers. So we put together what I think is a nice collection of just sort of general, somewhat challenging, but also somewhat run-of-the-mill cases that you'll encounter during practice. And it walks through the different approaches from less invasive to more invasive, from early presentations to later presentations, and from less and more definitive treatments based on patient preference, patient characteristics, and then emphasizes the importance of counseling and expectation setting.
No, I like that. And I think that many of our listeners will as well, really building that lesson around the way patients actually present. And, I think they'll find that the cases mirror the spectrum that is seen in the clinic, as you mentioned, from anything from watchful waiting all the way to the operating room. Let's talk about the first table in the lesson, the important aspects of the history to gather in a patient presenting with symptoms suggestive of Peyronie's disease. What are the key elements of the history and examination that every urologist should obtain, and why did you feel this deserved its own table?
Yeah, I think there's a lot of nuance to the information gathering in Peyronie's disease and in general in sexual dysfunction, and part of it is just establishing what patients think is important and worthwhile as far as goal and expectation setting. So, certainly a patient comes in and describes some new shape change to their penis, some associated penile pain, some palpable scar tissue. Those are all things that we expect. But some of the other characteristics that we try to identify and highlight are things like penile size change. And why is that important? Well, it's important because when we provide counseling and we think about the treatment options, some options are going to be more or less efficacious for those various parts of the presentation that they bring with them. But the other thing to think about here is that you want to take an entire picture of the patient's presentation, and so not in addition to focusing on their presenting symptoms, understand their past medical history, understand their surgical history, understand their social and family history, and what may be important in pertaining to the reason they're there and the ultimate treatment goals and what you can offer as a treatment.
That's a great framework. I mean, for those listening, really trying to get at a structured history that essentially triages the patient before you've actually done anything invasive. Another thing that lesson contains is an excellent summary of the collagenase treatment protocol. What practical pearls should people remember about this?
Yeah, I think there's a lot of nuance to administering collagenase. In general, the actual act of putting a needle into a palpable plaque is not in and of itself particularly challenging for urologic surgeons and clinicians who do this on a regular basis, but there's some nuance to just getting the best outcome. And so things that we like to highlight in our treatment protocol include considering the fact that, for example, many patients with Peyronie's will have a palpable plaque or scar that may not correlate exactly with the point of maximum curvature. So highlight the importance of considering an objective assessment of the curvature with an assessment of the erect penis prior to starting therapy. Even during the treatment itself, we think it's helpful to at least intermittently give an artificial erection test so you can actually correlate what you feel as far as the scar tissue with where that needle is going. Highlight the importance of not only administering the medication, but thinking about the postoperative expectations. Many of these patients are going to have pretty significant bruising and swelling. How do you wrap the penis? What are some adjunctive therapies that can be useful, such as penile traction? So I think that table was intended to highlight all of those considerations that are likely to get you the best outcome.
Absolutely. And I think that, as you mentioned, in addition to technique, counseling is just as important, if not more important. Nearly all patients may experience some pain or bruising and swelling, even hematomas. And obviously, I think you've commented on some of the trials. Do you have any comments on the kind of that post procedure counseling that you give patients in terms of, timing for intercourse and things of that nature?
Yeah, so the original FDA approval trials called the IMPRESS trials recommended a 2-week duration between the injection and considering penetrative intercourse. We recommend 4 weeks, and the idea there is that, in the way I counsel patients, is think about what the medication it's doing. It's creating a weak spot in the tunical tissue, which in theory could predispose to some type of buckling injury during intimacy. So if you give yourself a little bit longer time between administration of the medication and attempting penetrative intercourse, I think you're less likely to experience an injury. Certainly, it's possible to have a buckling injury even beyond that, but our rate has been significantly lower than that reported in the trials as a result of waiting a bit longer.
And one nuance I love about this lesson is the commentary about the mechanism of injury and why that may matter. So, in addition to the text, the table alone is worth a read. So I think it's certainly a protocol that folks who are listening can take straight into practice. Let's spend a few minutes on figure 2. This figure in the lesson really highlights the treatment algorithm for Peyronie's. Can you walk listeners through how you use this algorithm in clinic?
Yeah, so the algorithm differentiates, the classic dichotomy of Peyronie's, which is the active or acute phase and the chronic or stable phase, which is certainly an oversimplification, and it's based on sort of a clinical presentation and honestly clinician gestalt a little bit. But basically, during the active phase, when we follow the algorithm, we're looking at non-invasive options. And I would argue that runs the spectrum from observation, anti-inflammatories, all the way up to intralesional injections with things like collagenase. In contrast to that, the chronic or the stable phase, which we sort of generalize around 6 to 12 months with symptom stability for at least 3 months, that's when we can consider, again, all those other options we just talked about, plus surgical interventions. And the algorithm then goes in to describe what considerations may be associated with pursuing what specific type of surgery, plication, grafting, and penile implant.
Yeah, I think the figure two does serve as a true basis for decision making. And actually, the other figures in the lesson reinforce this visually. I mean, you talk about the goniometer measurement technique, right? Duplex ultrasound images, calcified versus non calcified flat plaques. I don't know if you could comment how these are integrated into the management of Peyronie's for our listeners.
Yeah, so I thought I would take this opportunity when we put together this case-based review to just find some photographs of what we experience and see in clinical practice. With there's so much heterogeneity in the presentations as far as the severity of curvature. There's even variability in how we apply like a goniometer, which seems like a simple tool to measure an angle, but depending on the location along the shaft, you can get a margin of error that can be clinically and certainly from a research perspective significant. Sometimes just simple things like identifying a calcified scar on an ultrasound, if you're not used to looking at those on a daily basis, can be challenging. So we provided some examples. Then the other thing I took advantage of with this, with some of our intraoperative photographs, was just highlighting what treatment options look like in the moment, right? When we're doing some of these complicated um, curvature corrections, what things look like extra tunicle grafting, which is a new technique that we talk about a bit in the review, plaque incision and grafting, plication, and penile implant surgery.
Yeah, I think the algorithm and figure are essentially a decision tree that you could even pin to the clinic wall to refer to, or for
Yeah.
those who are studying either for the in-service, the qualifying exam, or even the CUC. I think could be very high yield in the amount of information that's in that one figure.
Yeah, I agree. And honestly, when I read through these AUA updates, like I oftentimes print out a page or two. And I mean, I have them sitting all around my whiteboard in my office, because I think not just, my update here, but I think in general, many of these updates have such important resources that we can just quickly glance at. And, those are invaluable.
I agree. Matt, the case-based format of this lesson is particularly engaging, and there are three cases in the lesson. Can you give our listeners a high-level overview of what they can expect and maybe learn more about in these lessons?
Yeah. So I tried to choose sort of a broad range of presentations. One of the cases describes a patient presenting very early in their presentation, within a few weeks of their symptom onset, with mild curvature. And our treatment algorithm, as far as level of invasiveness and timing, is going to be very different in that setting, as opposed to a patient presenting a year out from onset of symptoms with more moderate severity curvature. And then the final case is a patient presenting with a common co-occurrence of erectile dysfunction. So now you're dealing with both curvature and erectile dysfunction. So I try to use those examples to talk through all of the different non-surgical and surgical options that we have based on the patient sitting in front of you. And you sort of think back to even that first table that we discussed, as far as what elements of the history and physical are going to dictate our clinical decision making.
Right. So three patients, three phases of the disease, and three very different destination. I think that's a real world spectrum for this type of situation. Matt, before we close, why should our listeners carve out time for lesson 24? What would you tell them are the most important messages that you'd like them to remember?
Yeah, I think this is an important topic, as you mentioned at the outset. This is something that we're all going to see. This is something that family members and friends are going to ask us about. And as urologists, even if we don't have subspecialization in this area, it's something that is important that we understand. It's also something that I think has a lot of nuance to it. And if nothing else, I think this review and the case-based approach sort of gives you a pause to think about why we make the recommendations that we do. And I liken this to when I give a talk and I talk about how, we have a hammer and a nail, right? Not every patient that we see is a nail for our hammer, right? We want to think about our entire tool belt. And I think this review gives a good overview of the different considerations for when a certain tool may be used. At the end of the day, the other important thing that I think we get across with this lesson is just the importance of shared decision making with our patients for this quality of life condition. Not everybody has the same goals that you may assume they have when they walk in the door.
Yeah, and you mentioned the tools that can be utilized to help manage this disease. And I think even over the years, the guideline itself has recommended, against a long list of historical oral agents, and you then evolved into traction devices, daily PDE5 inhibitors in the active phase. I think this lesson certainly brings you current, right, and up to date in one sitting.
Yeah, I agree.
So, I think, this is something that has been well said and outlined in the lesson, whether you're a resident, as I mentioned, preparing for exams, or a urologist in practice, updating your algorithm and clinical management. There's something to offer everyone in this. Matt, thank you for joining us today and for sharing your expertise.
Thank you so much for this opportunity. I appreciate it.
The combination of evidence, treatment algorithms, procedural guidance, and real clinical scenarios, I think, makes this a very applicable update series lesson for those listening. And to our audience, thank you for joining us. For additional educational resources, podcasts, CME activities, and the complete update series, please visit auanet.org/university. I'm Dr. Mark Gonzalgo. Thank you for listening, and we look forward to bringing you another episode of the AUA University podcast.